Hi, welcome. My name is Scott Suko, and I'm your Executive Director for the Liver Coalition of San Diego. And welcome to another session of our Liver Q&A liver webinars. Thank you for that. One disclaimer I want to say before we get started is tonight's presentation is for educational purposes only. This is not to be intended as individual medical advice if you're a patient or caregiver. Thank you for being here. Throughout the evening, you'll be probably coming up with some questions, and you'll notice that there is an opportunity to put them in the Q&A box, and then the moderator will queue those and make sure that the speaker gets to those either during the presentation or at the end. Before we get started, I wanted to highlight our industry partners who really make tonight's webinar possible. New sponsor joining us is Intercept Pharmaceuticals. So thank you, Intercept, for being here and supporting tonight's webinar. Also with us is Gilead. And Gilead's been a supporter of many of the webinars, and we appreciate them supporting tonight's as well. And then we have a special video from Eisai, and we'll watch that now. Excellent. Thank you, Eisai, and I saw Bobby earlier in the green room, so thank you for being here, Bobby. Next is Carl with Dynavax. Carl, welcome, and thanks for supporting tonight.
Thank you, Scott. Thank you so much for all the work you do with the Liver Coalition. Thank you to Dr. Frenette. Thank you, Shirley, for moderating. Dynavax Immunology is a fairly new vaccine company. We have a brand new 2-dose 1-month adult hepatitis B vaccine, and we are truly driven as a company to try to eradicate hepatitis B, which has no cure. So vaccinations become very, very important. It's wonderful to be partnering in San Diego because as a company, we started at UCSD in the laboratory. And what we hope eventually at Dynavax is to become one of the preeminent vaccine companies. And it's with partnerships like this that we strive to get involved with. And so thank you again, Scott. Thank you everyone who's attending. And I appreciate all you do.
Great, thank you, Carl. Next is our partners from AbbVie. They've also got a video, and we know that Elena's here in the green room as well. So thank you, AbbVie. Excellent, thank you, AbbVie. And our last sponsor to announce tonight is from Exalexis. And Susie's she's actually with us in the green room, but she's going to explain to us a little bit about this slide that introduces us to Exalexis.
Hi, everybody. As Scott said, my name is Susie Immel. I am the account manager in San Diego for Exalexis. And I just wanted to have the opportunity tonight, I really appreciate it, to present some of our access services here at Exalexis. We are considered kind of mid-level pharma, and sometimes people don't think that there are access services at companies our size. So I wanted to kind of highlight those very quickly. We have several programs to help patients start and stay on Cabometyx. Cabometyx is indicated for the treatment of patients with hepatocellular carcinoma who have been previously treated with sorafenib. So if you look at the bullet points there, up the first program, it's all labeled under EASE. EASE stands for Exalexis Access Services. And the first one is our 15-day trial program. It helps patients get on therapy very quickly. I highly recommend all patients take advantage of this program because it is independent of their insurance coverage. They are eligible regardless. They only need to have an on-label indication and be new to Cabometyx therapy. You do not need to have the patient sign anything to qualify or get enrolled in this program. And we can usually get patients their bottle within 24 hours. The next item on the list is our Quick Start program. It's for patients who are going to have a 5-day or more delay in getting access to therapy. Oftentimes, this might be due to a prior authorization approval delay. And this program, the patient receives up to a 60-day supply of Cabometyx. If the payer decides not to cover Cabometyx, the patient can enroll for free drug, and we'll talk about that in a second. The $0 copay program is self-explanatory. It applies to commercial-only patients. Our most popular program is the dose exchange program. It allows a patient to get one free dose exchange anytime in their treatment, meaning they will not have to pay a second copay for the new dose. All they have to do is send back their unused pills, and they'll get a 15-day supply of the new dose. Our patient assistance program is what I referred to before, and this is for patients who are uninsured or underinsured. And this program, they can be off-label patients. So they are eligible if they are off-label patients. Not listed here, and finally, we have a sample program. We urge you to take advantage of it. This allows bottles of 20, 40, or 60 milligrams to be shipped to your medical office. So my contact information is to the right. If you have any questions about any of those programs, please get in touch with me. Thank you so much, Scott and Dr. Frenette. I appreciate the opportunity.
Thank you so much, Susie, and welcome, and thank you for joining us tonight. Next, I'd like to hand it off to our board president, Terry Cunningham. Hey, Terry, welcome.
Hi, Scott. Thank you so much. Hello, my name is Terry Cunningham, and I'm the president of the board of the Liver Coalition of San Diego. And welcome to another informative seminar dealing with liver disease. We have experts providing very useful information. The Liver Coalition was founded last year to fill the void created when the American Liver Foundation decided to close their regional offices. Now all funds raised stay in San Diego rather than going to a national organization first. So please check our website for other webinars that have been completed, and they have a full listing of them on the website. And also look at our liver bridge walk that's going to happen on the 17th of July. We want to thank you for attending and look forward to seeing you at other webinars. I'd like to now introduce Shirley Sinoda, who is the co-chair of our Associate Medical Advisory Council. So Shirley, take over.
Thanks, Terry. Welcome, everyone. I want to welcome you to our liver webinar. Today, we're featuring Dr. Catherine Frenette. She is the medical director of liver transplant and also the director of the liver and hepatocellular cancer program at Scripps Hospital. And she's going to share with us her expertise on liver cancer. And so if you have any questions, I just want to remind you again to put them in the Q&A box, and we will make sure that Dr. Frenette has time to answer them. Dr. Frenette?
Hi, everyone, and thank you again for inviting me to present this webinar. And thank you, of course, to all of our sponsors. We would never be able to educate as we do. That is so important without our sponsors and their support, and of course, so important with helping our patients get what they need. So my job tonight was to talk about the leading causes and treatment for liver cancer. This talk is really geared towards allied health professionals of whatever specialty they happen to be. So if you're a patient watching this, thank you for watching. We do have a more patient-centric liver cancer talk, but you're of course welcome to see either of these. I will also say that I do have quite a bit of slides, so I might not make it through all of them, but I might come back and do an encore at some point. So thank you so much. I thought I would frame this by really talking about the most common patient questions that I get when I'm from a patient about liver cancer. So we all have, you know, some baseline knowledge to really help our patients to get through this scary disease. So just to remind everyone, liver cancer has a couple of names, and it is also known as hepatocellular carcinoma, which is the official name, but we also call it HCC. And throughout this talk tonight, I'll talk about HCC. We also use the word hepatoma often as well. And, you know, we'll hear some patients say, oh, my brother had liver cancer. It started in his colon, but that's different than liver cancer that's really hepatocellular carcinoma, which is starting in the liver. And that's really what we're focusing on. Excuse my dogs in the background. 'Tis the world of virtual webinars. So just a little bit of epidemiology to start. And why is this such an important cancer for us to know about? And even for those of us who may not specifically talk about liver cancer or see liver patients all the time, it's really important for us to understand this disease and know about this disease. HCC, or hepatocellular carcinoma, really accounts for the majority of cancers that start in the liver. And that's really what we're going to be focusing on. In 2018, liver cancers were the 4th most common cause of cancer-related death in the world. And just prior to that was the 3rd most common, but it is still very, very common as a cancer-related death. The World Health Organization estimates in less than 10 years, by 2030, we'll have over 1 million patients a year dying from liver cancer. So this is really skyrocketing. In the United States, the death rate from liver cancer has increased by 43% in just 16 years, from 2000 to 2016. And this is really one of the few cancers that is on the rise. In the United States, when we look at the top 15 causes of cancer-related death, you can see them listed here. And unfortunately, liver is one of the cancers that the mortality is actually increasing rather than decreasing. You know, many of our cancers we're getting better at treating. We're screening people and finding them early. We're doing preventative work like colonoscopies to remove polyps. Unfortunately, with liver, which was number 7 in 2000 to 2014, it's actually on the rise, and it's still continuing to be on the rise. Unfortunately, the reason is not so much that more people are dying when they have liver cancer. Like if you get the disease, it's more deadly now than it was 15 years ago. The problem is that we're having many, many more patients develop liver cancer. The rate of liver cancer development is just skyrocketing, and it's actually tripled in our lifetimes. And that's really because we're seeing more liver disease, and liver disease is really the underlying cause, and we'll talk more about that. When we think about how to stage liver cancer and what treatment options we think about, I always show this slide first, the BCLC liver cancer staging system. And this was just updated in 2018, and it's actually going to be updated again very shortly. But liver cancer is different than most cancers. So most cancers you'll talk about TNM staging, or tumor node metastasis. And it really, cancer staging for most cancers is just related to how much cancer is it, where is it at, and that's it. Well, liver cancer is different. And the reason it's different is because so many patients with liver cancer, most patients with liver cancer develop liver cancer in the setting of underlying liver disease, whether it's cirrhosis or hepatitis B or what have you. And what we find is that the overall survival really is affected just as much by the underlying liver disease as it is by the liver cancer itself. So when we think about the staging system for liver cancer, one of the things we always think about is what's the person's liver function, because that also will affect and determine what treatment options that we'll have. If you've got somebody that can't get a transplant and their liver function is end stage, that person is considered a terminal stage liver cancer patient, no matter how much liver cancer they have. They just have 1-2 centimeter nodule, and yet they have child C cirrhosis. Those patients are actually not candidates for anything except transplant. And so they're considered terminal. So this is why it's a little different. The BCLC staging system also helps guide us to what treatment options are best for each patient, whether it's surgery or transplant or ablation, chemo, what have you. It'll actually help guide us to the right thing. And it'll also help us determine what their overall outcomes will be. So I always I have this posted in my office, and I refer to it all the time, and we use this all the time. And so this is the staging system that's recommended, but I really just wanted to show it to sort of point out that the underlying liver function and health of the patient makes just as much difference as the actual amount of cancer that they have. So the biggest question I always get from patients when we're talking about liver cancer is, well, why did I get this? Where did this come from? And as I mentioned, most liver cancer in the US occurs in the setting of cirrhosis. And really, that can be cirrhosis from any cause whatsoever, whether it's viral hepatitis or alcohol or non-alcoholic fatty liver disease. All of that causes this chronic inflammation in the liver, scar tissue development, and that then causes increases the risk of hepatocellular carcinoma or HCC. So when I'm explaining this to my patients, I explain this to them like this is, think about skin cancer. What causes skin cancer? Well, chronic sun damage causes skin cancer. What causes lung cancer? Chronic lung damage from smoking causes lung cancer. Same exact process. Chronic liver damage causes liver cancer. And most of the time, there's something underlying the liver that led to the cancer in the first place. So when we think about risk factors and who gets liver cancer, it's really those people with underlying liver disease. So viral hepatitis B and C, alcoholic liver disease, non-alcoholic fatty liver disease, cirrhosis from any cause whatsoever, whether it's autoimmune or primary biliary cirrhosis, any cirrhosis causes liver cancer. We also know that other risk factors can be associated, like somebody who's diabetic has a double the rate of a risk of developing liver cancer. Obesity, cigarette smoking, being a man, unfortunately, increases your risk. Alcohol abuse, and then also iron overload. We worry a lot about patients getting iron overload that could potentially be contributing to development of liver cancer. So these are the things that I think about when I'm deciding, do I need to scan someone to look for liver cancer? When we think about viral hepatitis and liver cancer, again, we know that it's definitely a risk that we see. However, we also know that treating viral hepatitis decreases this risk, okay? So this was looking at both hepatitis B and hepatitis C. And what you'll see here is that in 3 years, in this meta-analysis of 17 different trials, in 3 years, about 10% of people developed liver cancer. But if they were treated, that decreased to 3%. In 5 years, it was 20% in 5 years developed a liver cancer, and that decreased to 5%. So one of the biggest things that we can do to decrease the chance of our patient getting liver cancer is to treat their viral hepatitis. We also know actually that statins can decrease the risk. Now, the data on statins is not yet strong enough that we're treating people with statins just to decrease the risk. However, I always like to show this because statins get a bad rap when it comes to the liver. I hear all the time, well, I was on a statin and it was stopped when they diagnosed me with liver disease. Well, we've actually now found that many patients who have liver disease can safely take a statin and actually can have that benefit them. We have found that the lipophilic statins are the ones that are really most beneficial with regards to the development of liver cancer. So those are atorvastatin, lovastatin, and simvastatin. Again, excuse the dogs, I apologize, I have a herding dog. And those three statins, if patients get liver cancer, are on those three statins, their rate of developing liver cancer has decreased by about half, okay? So the blue are people who aren't on very much, hardly at all. The brown are your sort of standard statin dosings. And you can see this cumulative incidence of liver cancer goes down by about half if they're on a statin. So please don't stop a statin just because of liver disease. The other thing that can decrease our risk of developing liver cancer is coffee, okay? So we've actually found that coffee decreases this risk. And when you look at people who drink 0 or 1 cup of coffee a day compared to 2 to 3 cups, 4 to 5 cups, and even 8 cups a day, that cumulative incidence or rate of developing liver cancer drops in half. Okay, so this is really important, and it's not just because coffee is amazing and delicious, but actually the European guidelines in 2018 actually put in their guidelines that coffee consumption has been shown to decrease the risk of liver cancer in patients with chronic liver disease. And in these patients, coffee consumption should be encouraged. So now whenever I'm seeing a patient with chronic liver disease in my office, from whatever the cause, I always ask them, do you drink coffee? And if they don't, I recommend that they drink at least 2 cups a day. I have not yet figured out how to write a prescription for this, but someday. Now, the other question I get, and even before people get diagnosed with cancer, is, with a patient with cirrhosis, for instance, why do you keep scanning me? What's the deal with this? Why do I have to keep coming back and seeing you? I feel fine and getting my scans. Well, the reason is because of we know that people get liver cancer not infrequently, and we need to look for it. So this was a study of patients with hepatitis C cirrhosis. This was looked at back before we had good curative treatments for hepatitis C. So this was untreated patients, but what they found was that liver cancer actually developed in 17 years in about 30% of patients. It was the main cause of death in 44%, and it was the first complication to develop. And again, we need to find these cancers before they develop symptoms, okay? What I always tell my patients, again, your football is the size, or your liver is the size of a football. I want to find your cancer when it's the size of a golf ball, and you can hide a lot of golf balls inside of a football and not feel it and not have any lab changes. So we have to scan people. We screen them. So what's recommended as far as screening is to really screen the people who are at the highest risk for liver cancer. So for hepatitis B, it's a little different because hepatitis B is a virus that can cause liver cancer even in the absence of cirrhosis. And so certain hepatitis B carriers or infected patients should be screened for liver cancer. That's Asian men over 40, Asian women over 50, if they have a family history of HCC, or if they're African or North American Blacks at any age. And then, of course, with cirrhosis at all. And anybody with any cirrhosis should be screened for liver cancer. We don't know about people who don't quite meet this level, like the hepatitis C with stage 3 fibrosis, although different guidelines do recommend screening those patients, or the patients with NAFLD who don't have cirrhosis. We're not exactly sure if their incidence of liver cancer is high enough to warrant screening. And this is a lifelong thing. So even if you treat somebody's hep C and their cirrhosis looks like it may have gone away, all that chronic damage is still there. They need to keep getting screened forever, And I can't tell you how many people have come in to see me with a new diagnosis of liver cancer and say, well, I had my hep C treated 5 years ago. They said my cirrhosis would get better. So they just stopped getting screened and now they've got advanced cancer. So in terms of how we screen, the American Association for the Study of Liver Disease recommends an ultrasound with or without an alpha-fetoprotein every 6 months. And again, that's lifelong. Now, most hepatologists do recommend adding that alpha-fetoprotein. And the reason is we know the sensitivity of ultrasound alone is 47%. But if you add that alpha-fetoprotein, the sensitivity goes up to 63%, which is definitely better. And that you have to remember, if you're doing the AFP and it's over 20, that should trigger doing a cross-sectional imaging, either a CT or an MRI. They also recommend if somebody has advanced cirrhosis, child C cirrhosis, do not screen them unless they're a transplant candidate, because again, their liver is now so sick that they're not going to be able to have any treatment anyway, so it's not going to benefit them. We don't recommend CT or MR as our primary modality for surveillance, really because of price. It is more expensive to screen with CT or MR, and in the case of CAT scan, you're then now exposing people to radiation, so that's not a primary reason to, not a primary modality for screening and surveillance. But if you have a patient that the ultrasound is inadequate, or you think they might have an inadequate ultrasound, like they're very obese, or they've got really a heterogeneous liver, then you can go ahead and use CT or MR. I tend to use more MRI than CT, again, because of that radiation question. They also recommend patients who are on the transplant wait list do not get an ultrasound. You should go to that cross-sectional imaging because it makes such a big difference. But again, realize, and the CT or MR must have contrast, and it has to be a multi-phase scan, which we'll talk about a little bit more in a minute. But that multi-phase scan is important, because if you have a patient that goes to the ER for abdominal pain and gets a scan, that's generally a single phase scan, and that's not going to be adequate for your screening test. So we have seen over and over in multiple different studies that patients who are undergoing screening and surveillance have their cancer diagnosed, they live longer than people who present just based on symptoms alone. Screening saves lives, period. So it is absolutely recommended to do this, and this is why we screen people. Again, we want to find it before they develop symptoms. There are some other blood tests that can be used. So I mentioned alpha-fetoprotein, which is often increased in other cases, like liver inflammation, for instance. It can also be elevated with other cancers, like embryonic cancers, like testicular cancer, or even gastric or lung cancer. So sometimes we'll actually use these other serum markers, AFP-L3, and then also the DCP, or des gamma carboxyprothrombin. There's not quite as much data for these two other serum markers, but I do find them to be useful in certain circumstances. And I also do them in patients on the transplant list, again, because it makes such a big difference to them if we miss a cancer. So again, alpha-fetoprotein, not perfect. So if you have one elevated level that's, mildly elevated, maybe it's around 15, with normal goes up to about 8 to 10 in most labs, you realize that it might not necessarily be cancer, but think about what other things could also increase the AFP level. But again, if you have a high AFP, you then have to go and do further imaging to make sure you're not missing something. The other thing about alpha-fetoprotein to remember is that about half of liver cancers do not release alpha-fetoprotein. So an alpha-fetoprotein alone is not a good screening test, because you will miss a lot of cancers that way. Oftentimes, too, the early cancers don't release as much alpha-fetoprotein as the later cancers, and of course, we want to find these early. So doing just an alpha-fetoprotein level is not going to be adequate. You have to do some kind of imaging with it. So we do have, the AASLD has released a screening and diagnosis algorithm to give us guidelines on what to do. So you do your ultrasound. If it's negative, then you want to repeat that every 6 months. And again, that's lifelong. if you do an ultrasound and it's got a very small lesion, maybe it's got a 6 centimeter or 6 millimeter lesion, you want to repeat that in probably a shorter time, maybe do it in 3 months instead of 6 months. Any ultrasound with a lesion of over 10 millimeters, or if their alpha fetoprotein is over 20, you need to go on and do your diagnostic imaging, which is that multi-phase CT or MR. And we evaluate these findings using what we call the LYRAS criteria. So the LYRAS criteria has been developed to really improve our reporting and interpretation of imaging tests for liver cancer. What we know is that arterial phase hyperenhancement, and I'll show you a picture of that, when your liver cancer enhances on the arterial phase, it often is worrisome for liver cancer. And these LYRAS criteria, again, look at arterial phase hyperenhancement, how big is the lesion, and then whether it's got what we call additional major features, whether it's got an enhancing pseudocapsule, if it's got washout, or if you've seen it grow. And then your radiology report should give you a LYRAS number. And if it doesn't give you a LYRAS number, it's not an adequate report, and you need to call the radiologist and ask them to give you a LYRAS number. This is just like when we get a mammogram and it comes back with a BI-RADS number, for instance. We use that in mammograms and have for years. It was called LYRAS to sort of hearken to that. So how do we interpret these LYRAS? Well, let's talk about this. So if you have, nothing on your imaging, then it's no observation. You go back to your surveillance every 6 months. You may have a LYRAS NC, which means non-categorizable, which often is when the triple phase imaging was not done right, or that, it was missed, and so they're not able to categorize it, so you need to repeat that imaging. A LYRAS 1 lesion is definitely benign. You do not need to worry about it. It's nothing to worry about, and you can guarantee to that patient they do not have cancer. LYRAS 2 is probably benign. You can repeat your surveillance imaging in 6 months, and you may want to consider repeating cross-sectional imaging like a CT or an MR in 6 months. Now, the ones that are more often that we see are the LYRAS 3, 4, 5, and M. So LYRAS 3 is intermediate. So that means we're not exactly sure what it is. It could be something worrisome, but we're not exactly sure. And you should repeat imaging in 3 to 6 months, but it needs again to be that CT or MRI. LYRAS 4 is probably liver cancer, and we recommend multidisciplinary discussion and may include a biopsy, or you could repeat or do a different diagnostic test in about 3 months or so. LYRAS 5 is definitely liver cancer. It's confirmed based on imaging. You do not need to biopsy that lesion to prove that someone has cancer, and you go ahead and treat. And then LYRAS M are lesions that look malignant, but we're not sure if they're HCC or if they could be something else like a cholangiocarcinoma or something. And those patients, you may want to biopsy them. We may do alternate imaging, but oftentimes these will get biopsied. So the reason that this is so important is, again, liver cancer is a radiologic diagnosis. We do not need to biopsy these things 95% of the time to know what we're dealing with. So our LYRAS 3 lesions, about 1/3 of them are malignant and HCC. LYRAS 4, it's about 75% HCC, 81% malignant. LYRAS 5, 95% are HCC, 98% malignant. This is why we say you don't need to biopsy it. And then LYRAS M, 37% HCC and 94% malignant. So again, there's something bad there. It just may not be HCC. So this is why it can be really, really useful. So this is what we're talking about when we discuss triple phase imaging. So triple phase refers to your non-enhanced scan, your arterial scan, and then what we call the portal venous scan, or equilibrium phase is the other word for it. And so what you can see on this scan, for instance, this is your non-enhanced, and here's your liver, and you can't really see anything there. But then on your arterial phase, you can see that there's this hyper-enhancing lesion. It's brighter than the underlying liver, and that is what is the worrisome feature. Then on the equilibrium or delayed phase, you can see that this is darker than the rest of the liver, and that's called washout. And the reason is because these tumors are fed by arterial vessels, whereas the liver is predominantly fed by the portal venous. So on arterial, the tumor is 100% enhanced and the liver is only about 10% enhanced. So the tumor is brighter. And on the portal venous, the tumor is not enhanced, but the liver is now 80% enhanced. So that's your washout, so to speak. And this is another picture that shows a similar thing. Again, brighter on the arterial phase, and then washout on your portal venous or equilibrium phase. And then you can see this one has this nice, what we call pseudocapsule, which is really like an inflammatory rim of the tumor pushing the liver out of the way and having inflammation around it. So these are definite HCCs, and we would go ahead and treat them as such. When we think about the sensitivity and specificity for CT versus MRI, in general, MRI is considered to be more sensitive and specific. The CT with or the MRI with EOVIST is about 94% specific for liver cancer. This is a specific contrast agent for the liver. Everything is better for the larger tumors over 2 centimeters, and for anything less than 1 centimeter, it's very difficult to tell exactly what they are. And oftentimes those smaller lesions will just say re-image in 3 months and see, are they growing, are they changing, what's going on. So the other patient question I get is, well, how can I have liver cancer when I feel fine? Why are you telling me I need a transplant if I feel fine? How is this happening? And really the typical presentation does not exist. There is no typical presentation. We want to find these tumors when a patient's asymptomatic, and we want to find it on a screening exam. That means we're more likely to be able to cure it. But patients can present with abdominal pain. They can present with chest wall pain, pleuritic chest pain, weight loss or anorexia. They can also present with their liver just getting worse. Maybe they have a new variceal bleed or they're newly jaundiced. That always worries me. Does someone have an underlying new liver cancer? So just realize that liver cancers often don't cause a significant specific symptom that is clearly this is liver cancer. And then the other question is, well, how, you're telling me you're 95 to 98% sure, but how about we just biopsy it and be sure? Well, biopsy really is very rarely indicated. And part of the concern, of course, is the risk, okay? So there is a risk of what we call needle track seeding or tracking of tumor cells. And that's pretty low. It's about, 1.5 to 1.5%. But if you've got somebody that has 1 2-centimeter tumor and now you biopsy it, and that's that 1 in 100 person that gets needle track seeding, you have now taken a curative cancer that you can cure and now turned it into a metastatic cancer. So that's why we really don't want to do this unless we absolutely have to. And these pictures are actually 2 patients of mine. This lady had a 2-centimeter tumor, was on the list to get a liver transplant to cure her cancer. And while she was listed, before she had come to see me, she had gotten a biopsy. And while she was listed, she's like, oh, doc, I'm growing this thing on my skin. What do you think this is? And we sent her to get it biopsied, and this is liver cancer growing on her skin. So she now has metastatic disease, and we can now not cure her cancer. This patient here, again, he had a LYRAS 4 lesion. We biopsied it, to make sure we knew what we were dealing with. He then went on to get a transplant, and a couple years after his transplant, he presented with this nodule right here growing in between his new liver and his chest wall. And this was a liver cancer nodule that was right where the needle had gone in, and the needle actually spread that cancer. So these are what we worry about. You also want to realize that biopsies can have a high false negative rate. It can be very difficult on a needle biopsy to actually know, is this a cancer or is this just a sick liver? So there's some series that the false negative rate was up to 30%. Higher rates even with smaller tumors where it's more difficult for the radiologist to actually hit the nodule. So if you have a biopsy that's done and it comes back negative for cancer, you can't just stop watching that nodule. You have to keep watching it, and if it grows or changes, again, rediscuss it at tumor board. The other risk is, these are vascular tumors. So again, I told you that these tumors are actually vascular and fed by the artery. So the rate of bleeding is not insignificant with biopsying these tumors, because you are putting a needle now into a really vascular tumor. So in this paper that was in 2008, the rate of bleeding from these tumors was about 0.4%. So 11 patients in the thing. 0.2% or 5 patients actually got that needle tract seeding, or implantation metastases is what we call it. And of the 11 patients that bled, 5 patients actually died from bleeding. So it was really very significant risk with biopsying these tumors. So we really think carefully about it. Now, I've mentioned transplant a couple of times in terms of treatment, and that's always, something I think about, because it is a curative treatment. And that's a question I get from patients is, well, can't I just get a transplant? So what we think about, we always want to think about with any cancer, of course, we want to think about curative treatments first. And really the 3 curative treatments are liver transplant, resection, and then ablative therapies, either radiofrequency ablation or microwave ablation. The other treatments that we have, chemoembolizations, yttrium-90 therapy or radiation therapy, targeted molecular therapy, and immunotherapies, it's really had some amazing progress with liver cancer treatment, but they're not curative. They just buy us time. So that's why transplant is really like considered the best in terms of curative treatment. We do have specific rules for transplant. So we have specific sizes, and they originally actually came out in early 1990s, called the Milan criteria. They're called the Milan criteria because they were developed in Milan, Italy. And what they found is that if you have a single tumor up to 5 centimeters in size, or up to 3 tumors, none over 3 centimeters, but no vascular invasion, no extrahepatic spread, these patients can actually have survival outcomes exactly the same as people who were transplanted for non-cancer indications. So overall survival at 5 years of about 75 to 80%, which is the same as non-cancer. They also found that if you were outside of these criteria, you had a much higher rate of cancer recurrence and your survival was decreased. And so we really think about these criteria when we're deciding, can someone get on the transplant list? Now, we have to put someone on the list, and they have to wait, and of course get enough points on the list to actually get to the top of the list. And what we actually have found is that there is a risk of dropout, is what we call it, which means you're waiting for your transplant and your cancer grows or spreads to now you're not in transplant criteria. And overall, that rate is about 20%, okay? We do know that some patients have very low rates of dropout, and that's patients who have small tumors, 2 to 3 centimeters. They get a single treatment to treat it, a single local regional therapy that's what LRT is. So a TACE or an ablation, and it looks completely gone on that imaging. And their alpha fetoprotein is less than 20. Those patients' rate of dropout in 2 years is only about 1.6%. People who do not have this, they've got a bigger tumor or multiple tumors, or it takes a couple treatments, their rate's about 26%. So we think about this when we're listing someone and giving them an idea of what's your risk of the cancer growing while you're waiting for a transplant. Now, the other thing that we've done more recently is actually made it possible to do what we call downstaging. So that's really taking a patient who would not normally be curative, maybe their tumor is 6.1 centimeters instead of 5 centimeters, and they're not a transplant candidate, and trying to treat them to get them to within transplant candidacy or within resection candidacy. And so what we've looked at is the different, sizes of tumors and types of therapies, et cetera. But what it boils down to is, if you're outside of Milan criteria, as long as you don't have vascular invasion or extrahepatic spread, then we can try to treat you and get your tumors to shrink to within Milan criteria. and be able to actually transplant that patient and offer them a curative treatment, even though they initially started outside of transplant criteria. So this is really where we're at now. And what I always say to, my GI and oncology colleagues, I say, if somebody does not have vascular invasion or spread outside the liver, they should at least have one visit at a transplant center to talk about whether they could be considered for downstaging to transplant. So, that's complicated, and there's a lot of treatments that we think about with liver cancer. And so, the patients are like, well, how do you decide what you're going to do? What's best for me? What's best for, how do you decide which treatment is best? And I always think about Joe versus the volcano. It's a balance between protecting the patient and treating the cancer. We don't want to be so aggressive with cancer treatment that now the liver function is starting to get worse and their liver fails while their cancer is controlled. That's not a success. So it's a balance, and we have to take into account things like, well, what's their liver function to start with? What's their performance status? What's their kidney function? How old are they? Do they have any comorbidities? And then where is the cancer? How big is it? How many tumors is there? What does it look like? And these things we balance and we discuss at our multidisciplinary tumor boards, where we have, all the specialists sit around the table and look at the scans and talk about the patients and talk about what the best treatment options is. And because of all of these different factors that have to be thought about, this is why multidisciplinary discussion is so, so important for each patient. So again, going back to that BCLC that I had mentioned, so, we think about the liver function, the performance status, but then we look at how big is the cancer, where is it at, and then that helps to guide us into which treatment can we offer the patient, okay? If you have, a single tumor, but normal liver function, no cirrhosis, then that patient would probably do best with resection. If you have multiple tumors, they probably should get a transplant unless they've got comorbidities, and then they should be considered for an ablation. If they've got portal invasion or metastatic disease, they should get systemic treatment. And this is really things we think about when we're thinking about which treatment is best for each patient. So we know the curative treatments, generally resection, transplant, and ablation, survival is more than 5 years. When patients are going for chemoembolization, it's about 36 months or so, give or take, although it's getting longer as time goes on. And then, when we're looking now at systemic medications, this is getting longer and longer and longer, and survival has been shown to be up to 14 to 22 months, depending, again, on someone's liver function. So, when we think about what's the best outcomes, again, transplant, but then resection, ablation, TACE, and then systemic meds would be somewhere a little bit under TACE. So that's sort of the order that we think about, okay? So when we're thinking about resection, the things that we think about, performance status, again, how sick is that patient? Can they tolerate a big surgery? What's their comorbidities? Do they have underlying heart disease? What's their liver function? Patients with livers with cirrhosis don't like to be operated on, and we certainly don't want to cause liver failure because we went to a resection. We have to look at how much liver are we leaving behind. And then we also look at the tumor characteristics. Where is it at? How much, are we gonna, is it right in the middle of the liver? Is it hanging off? We want to really should be resecting tumors that are solitary. We know that if you try to resect tumors that are multiple, you can actually have much more recurrence. So for the actual surgery, the morbidity and mortality is pretty low. It's 5% or less. And the patients can actually live quite long, somewhere around 50 to 70% at 5 years. But recurrence is the problem with resection. Okay, so with recurrence, we're still with resection, we're still leaving behind that liver that has cirrhosis or underlying liver damage, and that underlying liver damage and cirrhosis is what caused the cancer in the first place. And as I tell patients, when you go to the dermatologist with a skin cancer, it's not very often that they're just picking out one thing, they're burning stuff all over. Same thing happens with the liver. The damage happens throughout the entire liver. So leaving behind part of that diseased liver, you could have your original cancer come back, but you could also develop a new cancer. So these patients who get resected, I do MRIs on them frequently at the beginning. In the first 3 to 5 years. I do it every 3 years, or sorry, every 3 months I scan them. And then after 5 years, I only scan them with MRI, and I do it every 6 months. And that's because of this recurrence rate that's a problem. So, resection and transplant, that's a balance, and you're balancing the fact that you can do it right away and you're not going to have this waitlist dropout, but you're also then having to deal with these recurrence rates, and you still have cirrhosis. Okay, so transplant, you're getting rid of the cirrhosis, you're getting rid of the cancer, patients do great, but you might drop off the list while you're waiting. You could have, you have to be on immune suppression forever. You have to potentially have recurrence of the original problem that you had in your liver, like hep C if it wasn't treated, something like that. So it's really a balance between these two. So the other curative treatment that we think about is called ablation. There's radiofrequency ablation. There's also now microwave ablation. And really what that is burning the tumor. So we put a needle or a hot needle into the tumor, and we burn it, okay? And you end up with this sort of dead spot in the liver where the tumor was. Because it's used thermal ablation, what we see is the smaller tumors have a much better chance of having complete control, local control, 90%. The bigger tumors, not so good, okay, because it's just hard to get that big of a tumor completely burned and completely treated with ablation. So oftentimes with ablation, we're really thinking about tumors less than about 3 centimeters or so. We do know that the imaging does tend to underestimate how much necrosis there actually is in the actual after treatment. So, 2 studies here showed, 70% complete necrosis on imaging, but then when they actually took the liver out, it was only about 55%. This one, 75% on imaging and just 50% on explant. So again, it might look like it's totally dead, but you got to keep imaging and wait and watch it, because you may have some patients that weren't completely treated that will actually have your tumor start to have local recurrence. So the complications from ablation are really mostly related to the actual burning procedure. We do see incomplete procedures or missed procedures where the radiologist thinks that they're in the tumor, but then the needle didn't quite make it. There's also something called a heat sink effect, where if the tumor is right next to a big blood vessel, as the blood is flowing in that blood vessel, it prevents the ablative needle from heating up the entire area completely, because the blood is continuously cooling it. And so it will have an incomplete ablation along the area of the blood vessel. You can have tumor seeding from the needle. It can be painful. You can have a skin burn. You can develop infections. So these are all sort of things that we think about. Also liver failure, which has similar risks as TACE, which I'll talk about in a minute. But anything we're doing to the cancer, we're also doing to the liver. And again, it could cause your liver to get worse. So let's talk about TACE a minute, and really to understand how TACE works, you have to understand the blood supply of the liver. So the liver is the only organ in the body that has a dual blood supply. So it's got the hepatic artery that has the main arterial blood going in, which is what feeds the cancer. And then it's got the portal vein, which is the venous drainage from all the intestines and the spleen. So 80% of the hepatic blood flow is from the portal vein and 20% is from the hepatic artery. But again, cancers grow with arterial feeding. And so we actually use this to our advantage, where we can deliver agents mainly to the cancer and not as much collateral damage to the liver. So this is what a taste would look like. We put a catheter in the artery that is feeding the tumor. We get it as close as we can to the tumor, and then we can inject things. Oftentimes we'll inject little beads that are soaked in chemotherapy. We may not get a minute to talk about Y90, but Y90 uses a similar procedure, but instead of the beads having chemotherapy, they actually have radiation therapy where the beads have go in there and sit in there and deliver the radiation. But this is how a taste works. The catheter then comes out after the procedure, which takes about an hour to 2 hours, depending on how complicated the procedure is. And the patient usually either goes home that day or spends one night in the hospital. So we use TACE for bigger tumors, for multiple tumors, and so because of that, we don't see quite as good response rates, anywhere from 30 to 70%, again, depending on the actual tumor, the size, the location, the blood flow. And we use these beads. And the reason that we use the beads is because they work better. We have a longer time to progression. We also get less of the chemotherapy side effects, and we also get less of what we call post-embolic syndrome, where patients can get pain and fever afterwards. And what we've really seen looking at the most updated data is that our survival after TACE, this was based on 101 studies. So we see about 35% for survival at 5 years. We see about 50% at 2 years. So that's really what we're looking at now in terms of survival for TACE. So again, TACE is not a curative therapy. It buys us time. So we'll often use this in patients who are on the transplant list. We have to be careful again about underlying liver function because patients who have sicker livers tend to have more risk with the TACE or the ablation. So bilirubin levels, what's their child Q class, what's their performance status, what's their renal function, are they decompensated, things like this. And we're balancing again that liver function with having to treat the cancer. So I see we're running out of time, but I do want to just spend a couple of minutes on our systemic therapy. And this is really has such a huge progress in just the last 4 years or so. So our original systemic therapy was that worked for liver cancer was sorafenib, and that came out in 2007. Prior to that, we would use the chemotherapy that we would think about where, doxorubicin, and people would get all sorts of bad side effects, but it didn't really improve survival. Then we didn't really have very much at all until that worked until 2007 when regorafenib was approved. And since then, we've now had multiple therapies approved for systemic therapy for liver cancer. We'll use our multi-kinase inhibitors like sorafenib, lenvatinib, cabozantinib, regorafenib, and then we have our PD-1 inhibitors, nivolumab and pembrolizumab, although the FDA is now rethinking the approvals on these. And then most recently was the approval of the combination of atezolizumab and bevacizumab. And these are all systemic therapies that we think about with all of our patients who have the metastatic disease or vascular invasion. So the NCCN has updated the HCC management, and it's actually even had another update since I made this slide. So first-line systemic therapy is sorafenib, lenvatinib, or atezo-bev, and then there's multiple subsequent therapies that are can be used if a patient progresses. So what we've found is that as we have these multiple therapies that can be used, our patients are living longer and longer with systemic treatment options. And it's even more important to really make sure that we protect that liver function so that patients can really benefit from all the different treatment options that we have. So I'm going to leave it there and just say thank you everyone for listening. I'm sorry I had to go so fast through that. I always have a lot I want to say about liver cancer and liver cancer treatments. And again, thank you for supporting the Liver Coalition of San Diego. We're so very happy to be able to offer this education to our local people here.
Thank you, Dr. Frenette. We just have one question, one comment from one of your patients, Al Patton. He says he's celebrating his 9-year anniversary of his liver transplant.
I know. Happy birthday,
He probably
Al.
wanted to say hi to you. And then just, I think we have time for one quick question. Somebody wants to know, what is the percentage of someone getting HCC with cirrhosis?
So it's a really great question, and it really depends on what the cirrhosis cause is and whether there's ongoing damage to the liver. So for instance, for patients with hepatitis B cirrhosis, if their hepatitis B is not treated, it's about 5 to 8% per year. And again, that's cumulative, but if you treat the hepatitis B, that goes down by about half or more. Hepatitis C cirrhosis, it's about 3 to 5% per year. But again, if you get rid of the hep C, it goes down to about 1.5% per year. And then fatty liver disease, PBC, alcohol, the cirrhosis related to those diseases is around 2 to 3% per year. Okay, so really, when I'm thinking about what's my patient's risk of developing liver cancer, I think about, are they a man? What's the cause of their cirrhosis? Is there anything I could do to stop the liver damage? Just like putting on sunscreen to stop that sun damage when you're worried about skin cancer. Then I think about the alcohol, the smoking, the diabetes, the weight, and then I encourage the coffee, and that can, all those things can play into what that rate is.
Great, wonderful. Well, thank you so much, Dr. Frenette, for sharing your time and your expertise with us today. This is a wonderful summary of HCC. And we want to again thank our sponsors, and thank you all for attending.
Thank you,
Bye-bye.
everyone.
Good night.
Good night.